Just as a forewarning to everyone, my computer is sometimes deciding to turn off my video. I don't know why. If it does that, that's not what I'm meaning to do. So at the present moment, you should see my first slide. And I gotta bring up my notes. There we go. So thank you very much for having me today. I appreciate the invite. As Kelly said, I am from the Healthcare Access Project with the Michigan Advocacy Program. I will just kind of briefly introduce the Michigan Advocacy Program to everyone. MAP provides access to the justice system for those who need it most through direct legal help and statewide advocacy. MAP includes legal services of South Central Michigan with 5 offices in South and Central Michigan serving 13 counties, and farm worker legal services serving agricultural workers statewide. MAP also provides administrative services to 5 statewide specialty programs known collectively as MSAS. With the Healthcare Access Project, this is a new project that we are trying to ensure eligible individuals not only apply for coverage, but are able to obtain Medicaid coverage and maintain Medicaid coverage. So our focus is specifically on access to Medicaid services. We will assist with applications, including screening clients for eligibility, completing the Medicaid applications with the client, going through redeterminations with the client. You might have noticed that a lot of times clients will lose benefits because they don't submit everything that is needed in a redetermination or renewal process. So we're trying to prevent that interruption in Medicaid coverage by assisting them with these renewals. Oop, that moved forward before it was supposed to. Sorry about that. And then also assisting with terminations. So we are addressing coverage denials or closures and trying to help clients resolve those issues. So that might be if they were terminated because they failed to return something for a renewal, then we're assisting them with either appealing the denial or doing a new application. I was meeting with someone earlier today who was terminated in February, and she already had reapplied and was denied again. So I'm assisting her with doing a new application now and trying to get back benefits on Medicaid. And we are also assisting individuals with appeals. So we will support them through appeals processes when benefits are unfairly denied or discontinued. So the goal is to close the gap between eligibility and active health care coverage, helping vulnerable individuals access the medical care they need to stabilize and move forward. We are hoping, obviously, we serve a large service area with legal services. So we are using benefit navigators. Those benefit navigators are trained non-attorney volunteers who will assist our clients with actually completing and submitting their Medicaid applications. They will also be working with clients to gather any required documentation. So sometimes if they need proof of income from a pension company, clients may have difficulty communicating to the pension company what they need. So our benefits navigators will assist them with that process. Communicating directly with the state agencies, as well as tracking the applications through the approval process and troubleshooting delays. And obviously also just help with my bridges in general. I don't know how much experience everyone on the call has with Michigan's My Bridges portal that oversees food assistance and Medicaid assistance. But there's often difficulty actually getting access to your My Bridges if your phone number changed, if your If you forgot, you set an account up and then you set up a new account. We're trying to help people to make sure that they can access My Bridges so they can actually see their notices from DHHS without having to wait for the mail. In addition to the benefits navigators, we are also providing legal assistance. So that legal assistance would be provided by me as the staff attorney on the project, as well as pro bono attorneys that we will be recruiting. So examples of when we might provide assistance would be uh, assisting with alleged divestments. So if someone's being denied Medicaid coverage because the department thinks that they gave away an asset. I also had this as an intake just yesterday. A woman fell victim to a scam with involving cryptocurrency, and her spouse is now in a skilled nursing facility after having a stroke. So he needs Medicaid, but because of the scam, it looks like they've given away thousands of dollars due to whoever the scammer was. And if that is not given to DHHS in a way that they understand and can prove what happened, they'll usually deny those types of applications as having been a divestment, or not deny, but do a penalty for having divested assets. We also can appeal wrongful denials because income was miscalculated. I have another case where the Medicaid worker or the DHHS worker is including a child's income in their calculation, and they should not be doing it. So we're appealing that denial. And then one of our overarching goals is actually to identify some systemic issues faced by Medicaid clients so we can work to engage in impact work to resolve some of those issues. Some of the things that I've seen so far are early renewals. So currently, renewals are only supposed to happen every 12 months. I have been getting people who have received renewal requests after only 3 or 4 months. Or actually, I received one that was even earlier than that just the other day. So that is something that I've identified and we'll be working with hopefully DHHS to see if we can figure out what's going on and resolve that issue, because having these renewals happen more often is against policy right now and will cause clients to actually lose their coverage. Other programs or other services that the Healthcare Access Project is offering is actually partner training regarding Medicaid issues. So we have a Medicaid 101, where it's just a brief introductory training to Medicaid and Medicaid issues. We also have developed a training on the work requirements that are going to go into effect at the beginning of 2027 for some Medicaid recipients. And then also we are doing community outreach. So I have presentations scheduled in the community with Medicaid 101. I have presentations scheduled on work requirements. We'll participate in community fairs just so that we can get our materials out. Someone has a Medicaid issue, or they hear someone that has a Medicaid issue, they know where to send them. And then we're also hosting office hours in the community. So the office hours right now are primarily at all of our offices at Legal Services. So I have open office hours at the 5 offices that we have. That's Washtenaw, Monroe, Battle Creek, uh, Lansing, Ingham County, and Jackson is where those are currently taking place. And I'm working on scheduling office hours at other locations too. So our service area is the 13 counties that are highlighted. We are grant funded to include we are grant funded to provide services to anyone in these counties. as long as they meet our eligibility guidelines. For eligibility, our clients need to meet Legal Services Corporation guidelines. That's where we get this funding from. There is not an age requirement, but there is an income requirement and an asset limit. So due to this being a public benefit program, our client's income, the household income, needs to be at or below 200% of federal poverty level. So for a one-person household, that's $1,330 per month. I don't remember what it is for a two-person household, but or that's not 1,000. That's 100% of federal poverty level, sorry. For a one-person household, 200% is $2,660 per month. And then assets at or below $15,000. However, just like Medicaid, we don't include a primary residence. We don't include a vehicle. So there are things that are not included in that asset limit. And there are times where I actually am able to get a waiver of some of these restrictions. This primarily happens when it is related to long-term care Medicaid, where usually it's a spouse that needs Medicaid. Their combined assets are above the 15,000, but if they don't obtain Medicaid access, it's going to run through all of the assets that they have. And in those situations, I generally try to get a waiver from our program to make sure that I can still assist that person or that client so they don't have to use up all of their assets. The other last requirement is that they have to either be a citizen or a permanent resident, a lawful permanent resident, to be eligible for Medicaid. That is going to be pretty close to the Medicaid eligibility requirements soon anyway. Due to legislation changes starting in 2027, a lot of the categories of lawful immigrants will no longer be eligible for Medicaid coverage unless they are actually a permanent resident. So that is a change. So part of the reason I'm talking to everyone today is just so that you know that we exist as a resource. And if you have a client that needs assistance with Medicaid, you can connect them with us. So there are 3 ways that you can refer a client. One is just by giving them the phone number, which is on the screen. That is my direct number. So if they leave a message, if I'm not able to answer, I or a paralegal will call them back to take them through screening. You can give them my email address so I can schedule a time to talk with them. Or the clients can actually do an online intake through the website. Now, some clients I understand are probably going to be perfectly fine if you just give them my phone number or you give them the website, they'll move forward and they'll call, they'll be comfortable calling and they'll be comfortable filling out an online intake. For clients that need a warmer handoff, for clients that might need a little bit more hand holding, I am perfectly happy if you maybe send me an email saying, I have this client, this is their issue, I'd like to do an introduction. And if you include them on that email, or we set up a time, you can include them on that email if the client uses email, because I also know that your clients are generally going to be above 65. If your client uses email and they're comfortable with that, that works. Otherwise, if you email me, we can set up a time to have a 3-way call so that you and I and the client can all talk together and do the handoff that way, if that works best for you and your client. So client is independent, just go ahead and give them either the phone number or the website. If the client needs a warmer handoff, email to schedule a time to call. that works fine. So that is actually all that I have in prepared notes. I did get I'm going to stop sharing now so I can actually see everyone too. So I did receive a number of questions from some people regarding some clarifications on Healthy Michigan and Medicaid and the transfer of Healthy Michigan to Medicaid. So all of that was basically just an intro to my program so that you know I exist as a program. We exist as a program. Like I said, if you have clients that have Medicaid coverage and you either it's a complicated situation and you don't have time to spend hours researching this, then absolutely go ahead and send them my way. That is what we are here for, to make sure that you are able to assist all of your clients while we assist clients with Medicaid. Um, so for this clarification, I'm just going to bring this over so I'm not looking over to the side. I shouldn't have done that. My computer really hates me this morning. I think yep, camera got turned off. Okay. So just a brief answer to some of the questions that we received. One is, do Healthy Michigan Medicaid enrollees always need to initiate the Medicare Savings Plan or AdCare applications, or should caseworkers do this automatically? So when Healthy Michigan is a expansion Medicaid for individuals who are under 65 and not already receiving Medicare. They don't have any type of disability. So Healthy Michigan, once that person reaches 65, they no longer qualify for Healthy Michigan, but they may qualify for the Medicare Savings Program or for AdCare, the Medicaid for individuals who are older or disabled. When Department of Health and Human Services is set to terminate someone from a Medicaid plan, they are not supposed to just outright terminate them. They are supposed to actually evaluate that person to see if there are any other plans that they qualify for. So if someone is being terminated from Medicare from Healthy Michigan, the caseworker, they'll receive a notice saying that they are being terminated from Healthy Michigan, but they then should be assessed for any other types of coverage before they are terminated entirely. That means that because Healthy Michigan does not have an asset test the same way that other Medicaid programs do, that means they could be getting a notice requesting information regarding checking account statements, savings account statements, and other assets before they can actually be approved for a different type of Medicaid program. Now, issue, of course, is that things don't necessarily always go the way that they are supposed to. So if the person receives a notice saying that they've been terminated from Healthy Michigan, they'll have an effective date on that notice. If they don't receive a new notice by that effective date, either requesting additional information or a new notice saying that they are eligible for or approved for a different plan, then the next step is to actually contact Department of Health and Human Services to make sure that they are actually evaluating that client for another type of Medicaid plan. I'm looking at the rest of this question. One of the parts of the question is, are there often two determination notices that seem to say contradictory things? Absolutely. That is true just for Medicaid in general, unfortunately. They'll receive, what I've been told is basically any time that a case is touched, if it changes anything about that case, a due notice can be sent out. So they may very well receive a notice saying that they are being denied or closed Healthy Michigan because they no longer qualify. And then a day later or a week later, they'll receive a new notice saying that they are qualified for another program. Or they'll receive another document requesting additional information, and the client will wonder, why is additional information being requested? I've already been told that Medicaid is being cut off because Healthy Michigan's being cut off. Why do they need more information? And they need more information because they need to confirm that the person actually qualifies for a different Medicaid plan. Medicare effective date. This means the new Medicare beneficiaries can't sign up for the dual plan, take effect once I'm start say some say see Healthy Michigan Medicaid. Say that does not qualify for a dual plan if beneficiaries are clearly AdCare eligible, we can sign them up for Part D and assume they will either have holdover Healthy Michigan or Medicaid in their first month. The second long question is far more complicated. The second question is regarding trying to get someone on both Medicare and Medicaid as on a dual eligible program before Medicare actually takes effect. If Medicare has not taken effect, then they'll still be on a Healthy Michigan plan. You can't be on Healthy Michigan and Medicaid at the same time. Eligible, we could sign them up for Part D and assume they will have holdover Healthy Michigan first month. So I'm going to ask this person to probably talk to me separately after I've had more of an opportunity to look into this. Because, like I said, if someone is on Healthy Michigan, it's because they are under 65 and not disabled. As soon as someone is on Medicare, that means that they are either over 65 or disabled. You can't be on Healthy Michigan and Medicare at the same time. But you can't be on a more traditional form of Medicaid until you are over 65 or disabled. So the special needs program, dual eligible programs are actually correct when we're talking about initially getting someone enrolled. It is difficult to get that to go at the same time. The person that asked this question, I'm going to say, let me look into it and I will get back to you. And that's what questions do people have?
Anybody have any particular questions or case scenarios that you've run into where we can ask Kim for some guidance on that? Michelle, I had a question for you while you're here. When you're over at MCOP and you have the clients that are both Medicare and Medicaid, do you all run into challenges? There is an office for the health access, the program, the Healthcare Access Project in Monroe for folks in Monroe. So just if you have any questions or anything, please ask now. We have Kim here and we can all learn from our questions to her.
So this, I mean, it could be a question about Medicaid, it could be a question about the program. I like talking about Medicaid. It's kind of very strange. But I do.
Well, I'm glad you're in this project then, because that's where you're needed, that's awesome.
So someone just asked, where is the Monroe office located? So it is the legal services office in Monroe. I actually have to turn off my camera again. I don't understand what's going on with my computer today. It's throwing a fit. So legal services office in Monroe. I don't have that one memorized. It's on South Telegraph, which I know goes through much of Monroe, but it's on South Telegraph in Monroe. I have open office hours in Monroe, so I'm only in Monroe one day a month. I believe that the office hours flyer was shared.
Yeah, I'm
Yeah.
gonna send that out to everybody today. Yeah. The second Tuesday of every month from 10 to 1 at the Legal Services Office of South Central Michigan at 898 South Telegraph.
Yeah.
I didn't want to overwhelm everybody with all of the information before they had a chance to meet you. So
Yeah, that's fair.
yeah.
So then I see that several at McPop are already My Bridges Navigators, which makes complete sense. The difference with the benefits navigators versus My Bridges Navigators is we are specifically funded to assist clients with doing these applications and getting supporting documentation and talking to DHHS and appealing DHHS and arguing with DHHS. So like I said, if it's something that super easy, you can handle it, absolutely go ahead. I'm not trying to take anything away from you, but if there's a case that you do not feel like you have the time or capacity to deal with, that is what I am here for. And that is what my program is here for. First, I want to have the application because that isn't showing. So often difficult to coordinate the start. Yeah, that is true. That is incredibly true. AdCare, AdCare will not show until the person's actually approved for AdCare. So say Healthy Michigan stops in March, they will be approved for AdCare starting in March, but they might not get that approval until April. So AdCare will be effective back to March. Yeah, there we go. Sorry. AdCare will be approved back to March, but you will not be able to actually start the dual plan until AdCare has been officially approved by DHHS. Yes, that is incredibly frustrating. That is just part of how DHHS takes longer to process things because they have to actually have a 10-day period where they give you notice that something's required, then you have 10 days to return it. You can request extensions if you don't have those things. It just takes a long time. So yeah, there's not a good answer to that, unfortunately. For scheduling a time to talk to me or just popping in, scheduling a time to talk to me is best way to go. Because my main base is in Washtenaw. So my main base is at the Ypsilanti office. If you want to talk in person, then I need to know that. So I will actually be there in person. Um, so if there's any time that you guys have, like if you have a client that you wanted to have me meet with in person, that's a great way to do it. Um, if there is just someone that you want me to talk with, then like I said, email me and we can schedule a time to talk. There is the Medicaid 101 training is not online yet. That is something that I'm working on doing. It's it can be in person or it can actually be via Zoom or through another type of training. So it's really they're scheduled through different programs. So if the program wants to have it, I will set up a time to do the presentation with them, and it can be in person or it can be virtually. There is a plan to record that at some point. It has not happened yet.
Yeah, we'd be very interested in that, Kim, just so you know. As a group, I'm sure there's quite a few folks that would like that. A question that I have is with one of my other folks in another county that you don't cover, but I'm going to take advantage of your opportunity of, having you here today. The person applied for Medicaid and they haven't heard anything, and it's been months. So, you know, is it,
There's
what's the turnaround time from when you've sent in all your paperwork for that redetermination? You've sent everything in. What is their allowed return time that they're supposed to respond to you?
their standard of promptness, so they have in their policies a required standard of promptness. And I believe it's 45 days for their standard of promptness to actually
45 days.
process.
Okay. So that's a month and a half. So they're probably thinking, hey, we're close to our 45, even though it's a little over. But okay. So it's 45 days because everybody asks me, and I had no idea what their number was for response time. So
So
thank you.
it does. I'm going to stop messing with things on my other screens because it seems to be that's what's causing the issue.
Mm-hmm.
Um, so the standard of promptness does vary depending on the specific thing, but their standard of promptness for actually making a decision is 45 days. That
Okay.
can actually get pushed out if they've done verification requests and things, but otherwise, I'm pretty sure it's 45 days.
And that's with the person who's already been on Medicaid before, and then it was a redetermination. They asked for more, documentation for whatever it was, and it's still longer. You know what I mean? It's not like it's a brand new case and they're doing all that research. You know what I mean? So that's where
Mhm.
they were a little confused trying to figure this out.
So the biggest concern that I have when there is that kind of delay
Mhm.
is DHHS coming back and saying, well, we never received it.
Okay.
That is usually what the response ends up being if it's been that type of delay. That or, oh, we sent a notice and you just didn't get it.
Right. Yeah. Okay. Lily has a question. Go ahead and unmute you, Lily.
I can appreciate that this could be, a little bit hard to answer, but can you go over how Medicaid would put somebody into a spend down? Because I've had some clients who are not very high over the Medicaid limit, but somehow their spend down is just a little ridiculous. And it
It's
just doesn't make
probably
sense.
it's probably a lot ridiculous for a reason that is absolutely horrible. So, thank you for that question. When there are types of Medicaid programs that are more forgivable regarding limits, Michigan does not have those types of programs. So if someone is even a dollar over the income limit, then that is when they are put into spend down. Their spend down is determined based on there is a protected income level that is in policy. So that protected income level is the starting base. Anything above that protected income level becomes a spend down unless there are other offsets. So other offsets could include other types of expenses, if you have children, things like that. Unfortunately, the protected income levels have not been updated since the last I heard it was the 80s. It's actually unclear the last time that they were updated, but I think it's the 80s or 90s since that income level has been updated. So that means that for a one-person household through most of the state, absolutely, that is the correct response. Through most of the state, for a one-person household, the protected income level is like under $500 because they did that calculation back in the 80s or 90s to see how much someone needed to survive month to month. And at that time, this is what's been told to me repeatedly. At that time, the primary out-of-pocket cost was food. Now, the primary out-of-pocket cost for individuals is housing. So the spend downs are so horrible because anything above that protected amount becomes the deductible, becomes how much has to be spent. There is actually movement by multiple groups to update that, where basically the spend down should just be the amount of dollars that you are over the eligibility cutoff. So if the eligibility cutoff for a program is 100% of federal poverty level, and you are $10 over it, your deductible is $10. There is a movement to try to do that, but it has not gone anywhere so far. So that is the reason. It's a horrible reason. But hopefully it makes a little more sense now.
That does. Thank you. What that last part made sense. That's how I would have thought it would be in my head. But okay. Well, that is good to know. Thank you. Now I can actually go back to clients and kind of explain this because that's a big question. I have a lot of clients who come to me with spend downs and we're stumped by the amount that they have to pay, and it leaves them with practically nothing, or they just can't meet that criteria for the spend down because they're like, I'm sick, but I'm not that sick. So,
Yeah.
okay. Okay, thank you for that.
Yeah. Yes. So Peggy, Washington Health Project has been doing Medicaid trainings, has been doing a number of Medicaid trainings, primarily on Healthy Michigan, and talking about the income calculation and eligibility. I didn't qualify. On some general questions, some Medicare beneficiaries misunderstand what a DH has told them. Yeah. So I do highly recommend the training from Washington Health Project. I think they are still putting them on pretty regularly. And I don't think I ever talked about my actual background. My background, I've been in elder law of some form or another for 13 years. I started at Legal Services in Wayne County, specifically working with caregivers of older adults. So caregivers, they were primarily coming to me because their loved one was in a nursing facility and they suddenly needed to get eligible for Medicaid. After that, I worked in private practice for the last 4 years, again, doing elder law and again working on Medicaid and estate planning and other elder law issues. I felt called back to public service, and now my whole life is Medicaid, and it's for older adults and it's also for younger adults. So we work with any type of Medicaid, really, including access to services. So for instance, if someone is saying someone's already on Medicaid, but they are saying that Medicaid is not approving the expense for a specific service that should be covered by Medicaid, that is also something that my office will get involved in. Does anyone have any other questions for me?
I have a question, Kim. So Medicaid's moved to this universal caseload kind of setup. We used to have a name and a number to
Yeah.
call. The person had their worker. And I'm hoping with you having this project in this program that you might have an in with, somebody at MDHHS. We've been working on that, trying to figure out if we can kind of figure that out ourselves. But with at least with working with you and having that in with MDHHS, I think that's huge. That's a huge, because we run into that where we can't find anybody who can consistently know what we're talking about.
Yeah.
Yes.
So part of what I'm doing is building those relationships as much as I can so that we can consistently talk to the same person, or at least someone who knows what's going on with their case. So yeah.
Thank you.
Universal caseload is a mess. It's just a mess.
I think the idea might be a good idea. Whoever answers the phone, oh, I've got somebody, but then you're doing the same thing over and over again, telling them, the situation and whatever. But before, my folks weren't able to reach their worker. They would call and they wouldn't get in touch with them and they wouldn't call them back. And so I don't know what was happening there. So I can see the pros to it and I can see the negatives to it. So,
So there is a number, there's an 800 number to reach a specialist at DHHS, and it will be a specialist for the county that the person is in. They can see the records, but it is not always going to be the same worker.
Right.
So the number that is on notices, that 844-46, whatever, you'll be able to reach a specialist, presumably, because the other issue with that, of course, is the wait time. So because once you get into the queue to talk to somebody, you're given the option to have them call you back or just to wait on the line until someone answers. And how long you're waiting, it's difficult to know how long you'll be waiting. Oh, no, that number does not look familiar. What I have learned, so if anyone does call DHHS either with a client or on their own, my understanding, so that's for ordering a My Health card online. There you go. So my understanding, if you are calling, they have lunch from 12 to 1, I want to say. The line is closed from 12 to 1. So if you call and you enter the queue for a call back, I am not sure if that queue maintains after they come back from lunch, but I know that it does not. Yeah, they stopped taking calls early. But I know that the queue does not continue from one day into the next. So if you call on Monday and you did not get a call back on Monday, you need to call again on Tuesday in order to request a call back again on Tuesday. So what I've started doing for some of my counties that are busier is actually calling as soon as they open so I can enter the queue, and that increases the likelihood that I'll get called back on that day so that I'm at least early in the queue. 3 or is it 4 that they stopped taking calls? So I don't remember if it's 3 or if it's 4 when they actually close the line down, but I don't call that late in the day because the likelihood that I'm actually going to talk to somebody is so low. So that's just my own practice.
Kim, I have a question. So are they wanting clients to come into their offices with the paperwork and all of that?
No,
Okay. They
no.
want, yeah. What is the preferred way to submit their applications? And I mean, through the My Bridges, through, and then online. And we have people that don't have a computer, don't have, how do I scan this document? You know what I mean? So it gets a little tricky.
Yeah. So their preferred way is always going to be My Bridges because that automatically updates into their case system.
Okay.
Um, for there are different levels of there are different levels of partners, community partners. So there is a level of partner that just has basically a computer where the person can get access to My Bridges at that space.
Mm-hmm.
Um, so if they're able to set things up through My Bridges at that partner's location, that will work. One of the things that, like I said, my office does is make sure that we try to get access to My Bridges if possible. And if that means we're creating an account and we're creating an email account for our client, then that is what we're doing. Obviously, we're giving them all of the login information for it so that they
Mm-hmm.
can maintain it. But we're trying to get those accounts created because that is the guaranteed way to actually have it be, that's the guaranteed way to make sure that DHHS cannot say we did not get this thing.
Mm-hmm.
The alternative is the preferred alternative depends on the actual county. So some counties do prefer that you use their email address, like their general email address, which typically is, so they have the, let me bring up, let me see if I can find a notice real quick. I was just working on one of these earlier. There we go. So the specialist ID on the notices. The specialist ID at michigan.gov is the email address for the uniform or the universal caseload for that county. Now, some counties prefer that you use that if you're not able to use My Bridges. There are some counties where they consider that an internal email, and you don't find that out until you email that to them. For Washtenaw, I want to say the uniform caseload, that that email address works. So if you can't do My Bridges, you should be doing email. If you can't do email, because obviously there's still going to be clients that don't have an email address, you're working with an older population, then my next go-to is fax. And the reason for that, again, is that you get a confirmation that the fax was sent and received. So even if the response is, I did not receive it, if I have that document proving that the fax was sent and received, I can get the case reopened with that information.
Would you know about the Monroe County or Livingston County with regards to the preferred email or the phone
Monroe
call?
County, Monroe County, I do not know because I haven't had too many cases in Monroe County yet. I need more
Okay.
cases
Mhm.
there.
Okay.
Livingston, kind of want to say it was Livingston that sent me that email saying this is a private. Sorry. I'll look to see about Livingston and I'll let you know so you can pass
Okay.
it on.
Okay. Perfect. Thank you. Any other questions? Well, Kim, I want to say thank you very much for your time today. It's been very helpful, and we're so glad you're there. And your program is there and available as a resource. And we've got contact information now. So your email, your phone number, and then the website for the online application. Thank you very much for all of that. I will send out the other additional information that Kim shared before, so that you have that information for Monroe and Washington for the locations and the contact and the office number, hours, and all of that. And you're available for any other email questions that might come up, or scenarios and all of
Yep.
that. Thank you very much. Thank you,
As-
Sharon. Any thoughts?
No,
So,
I just thank you for your time and the
Yeah.
resources that you provided to the team. It's definitely been beneficial. You see by the question. So thank you. I appreciate it.
As I said, I actually like talking about Medicaid. So even if you, because I know that you guys also serve counties that are not in our service area. If you have a question, feel free to email me. If I know the answer, I'll respond.
Thank you. I appreciate that, because I kind of felt bad because my counties aren't in your area. So I'm like, what? I've got two counties and I have Medicaid questions all the time. So thank you for that.
I'm
Yeah,
kind
I
of a
appreciate
freak
that.
and I like talking about Medicaid, so.
I appreciate that. And I appreciate that you're available to help with appeals and those complicated scenarios where the person gets stuck and then, it's very overwhelming. So I'm glad that you're there. Your group is there. Your folks are available. So thank you very much. Thank you again for your time, and we appreciate you very much. Thank you.
All right, thank
Absolutely.
you. All
Thank
right,
you, guys.
okay. All righty.
And thank you all
Bye-bye.
for attending.
Thank
All right.
you. All right.
All
Thank
right,
you.
bye-bye.
Bye. Okay. All right.